Hello, my name is Professor Raj Sengupta, consultant rheumatologist at the Royal United Hospitals Bath NHS Foundation Trust. In 2021, the National Axial Spondyloarthritis Society launched the Act on Axial SpA campaign. I was one of the clinical advisors alongside Professor Carl Gaffney in Norwich. Our aim was and remains to cut the historic 8 to 9 year time to diagnosis down to 1 year. Today, I'm going to show you a practical way to do that, the Axial SpA Playbook, and how you can use it to make immediate, measurable progress in your local area. Here are my disclosures. So across the UK, brilliant projects have been done to reduce the delay in primary care, in secondary care, and within rheumatology. But we recognise that patients also touch lots of other services, including dermatology, gastroenterology, ophthalmology, and radiology. So we needed a way to stitch the whole pathway together, highlight pinch points, and give teams clear, repeatable actions. That's exactly what the playbook does. It organises the pathway, provides checklists, resource links, and case studies, and helps you prioritise and measure improvements locally. Think of it as a practical guide rather than a policy document. It's structured around the journey from public awareness to primary care, secondary care, rheumatology, and then patient information and self-management. Each section includes a concise checklist you can use to track your progress, plus links to tools, templates, prompts, and protocols, and examples from sites that have already done the work. It also emphasizes data as the objective measure of improvement. Understand your baseline, set targets, and track change. You can get a copy of the playbook using this QR code. So if you only remember one slide, make it the implementation plan on a page. It sequences activity into 5 logical steps. Understand your service and build the team. Implement quick wins. Develop, enhance your Axial SpA service, strengthen referrals, and reach the unreached, the people who are not yet in your clinic. Each step maps to specific good practice points and tools in the playbook so you can work through it methodically and show progress. The contents of the playbook are listed here, and I will go through these in a little more detail. So in the enabler section, there are 4 enablers that underpin a high-performing service. A clear inflammatory back pain pathway aligned with getting it right first time in rheumatology or relevant national guidelines. A specialist Axial SpA service, ideally a dedicated clinic with MDT capacity, a named local lead for Axial SpA, and a financial case for change using the NASS economic model. What you see here, the resource links on the right for each section, and case studies and publications giving you examples where things have already been done. And as you go through completing each activity, what we would envisage is you can tick each of those activities off as a record of the achievements. So I want to spend a little bit of time now talking about the NASS UEA economic model tool. Within the playbook's enabler section, NASS recommends creating a financial case for change using the NASS economic model and the links to downloadable cost of delayed diagnosis toolkit. The model, which has been developed with the University of East Anglia, lets you quantify the local financial impact of delayed diagnosis and estimate the savings achievable when you shorten the pathway. In this way, you can make a robust business case for pathway change, clinic capacity, imaging protocols, as well as primary and secondary care interventions. So this is a step-by-step guide for you using the cost calculator for your area. You identify the local adult population for your area. The toolkit will automatically tell you how many AxSpA patients are likely to be in your area. You then input your current time to diagnosis, and the time to diagnosis you want to get to, the tool then calculates the cost of delayed diagnosis per patient and helps give you some targets to show benefits. Here is an example of a page of an individual center, and you can see all the different areas I've talked about, and at the bottom you will see the cost saving that's potential if a delayed to diagnosis is achieved in your area specifically. So overall, with this whole program and the playbook, we start with data, because that what we measure we can actually change. The playbook will set out a framework to gauge the efficiency and effectiveness of your diagnostic processes, submit data to the NASS Time to Diagnosis Patient Survey, and if you are in England or Wales, the BSR National Early Inflammatory Arthritis Audit. This way you understand your local AxSpA population, the numbers of patients that have been diagnosed, referred, and conversion rates, as well as MRI volumes under a spondyloarthritis protocol. It also covers estimating unmet need to anticipate demand from both primary care and extramusculoskeletal manifestation services. So what are your first actions? Put a measurement framework in place. Enroll in the national audit. Quantify unmet need with primary care and EMM colleagues, and track the time to diagnosis. In the next section, we talk about the patient voice. The playbook recommends patient and public involvement in every improvement project, routine feedback loops, and in-person diagnosis conversations, shared decision-making, and treatment plans that reflect each person's goals and context. It includes tools for co-design and agenda setting, so we build services with patients and not for them. The playbook supports local awareness campaigns targeting under 40s with chronic inflammatory back pain, promoting the SPINE acronym and directing people to use the NASS online symptom checker. In this way, they can print the result and take it to the primary care healthcare team. There are poster packs, social assets, and examples from centres that have run geo-targeted campaigns ready for you to adapt. A quick win here is to embed the symptom checker link in GP and FCP appointment text, so it becomes part of the triage rather than an optional extra. In primary care, the message is simple: raise suspicion and refer urgently when AxSpA is likely. The playbook points to rolling education and to electronic tools that make identification and referrals an easy process, like pop-ups for primary care IT systems. Here an example might be the Primus tool developed with the University of Nottingham. There are also the Arden's MSK templates, the SPADE tool, and clear referral proformas that capture symptom criteria. It also encourages pragmatic symptom relief with anti-inflammatories or physiotherapy while referral is in motion. So what are your next steps? Identify GP FCP champions in your area. Switch on real-time prompts, templates in eMission System 1. Standardize referral criteria and proformas across the locality, and utilize advice and guidance as per the GIRFT template. With regard to extra musculoskeletal manifestation services, we know that people with uveitis, psoriasis and IBD often pass through secondary care long before they see us in rheumatology. The playbook lays out how rheumatology should know the named leads in ophthalmology, dermatology and gastroenterology, provide regular teaching and two-way advice and guidance, put in place simple internal referral routes such as phone a friend or formal pathways, use quick triage tools like the Back Pain Plus posters, symptom checkers and referral prompts. Within rheumatology, the playbook is explicit. Patients should ideally be assessed in a specialist axial spondyloarthritis clinic with MDT input. Where MRI is necessary, there should be an established spondyloarthritis protocol MRI covering the sacroiliac joints and spine with T1 and STIR sequences, and importantly interpreted by specialist musculoskeletal radiologists. There should be regular dialogue between radiology and rheumatology. There are links to the Brit SpA recommendations, GIRFT, and examples of successful local protocol implementations on this page. Actions here include a joint MRI protocol with MSK Radiology, an agreement on who reports these scans, and ongoing cross-teaching so requests and reports are consistently fit for purpose. Receiving the right information and support at the time of diagnosis is key for the best patient outcomes. The playbook gathers patient-facing information which includes the Your Space self-management resource, a full suite of NASS guides, MDT referrals including physiotherapy, occupational therapy, psychology, and options for physiotherapy-led peer support through local or online NASS branches. It encourages service to design and deliver supported self-management sessions and to offer a helpline for support between appointments. So, we know as clinicians we are very busy. Looking after patients is a full-time job. The playbook is intentionally modular. You pick one activity, follow the how-to with examples, tick it off and keep a simple record. We've completed activities 1 to 10, the next number is 11. That's how we turn the ambition into reality, incremental wins that add up to a faster pathway. To support spread and learning, NASS will act as a central hub. Your centre can complete their local playbook and then feed back to NASS regularly, and NASS can then monitor the national state of play. Surface what's actually working, share it with others as good practice. NASS will use feedback and focus groups to regularly evaluate the effectiveness, usability and relevance of the playbook, and of course update it periodically. So what should your first 90 days look like? If you're wondering where to start on Monday, name the team and the lead. Put Axial SpA on someone's job plan and convene primary care, radiology and EMM specialties. Baseline your data, join the audit, measure time to diagnosis, map conversion rates and estimate unmet need. Switch on prompts, deploy primary care pop-up tools such as Primus and the Ardens templates, and embed the symptom checker into GP and FCP workflows. With your radiology department, agree the MRI protocol and reporting arrangements with the team. Run an awareness micro-campaign in your area, targeting the under 40s with chronic back pain, and set up a referral pro forma that everyone uses. In addition, set up or protect your Axial SpA clinic capacity and align your clinic with MDT input. Activate patient support. Give every new diagnosis a clear information pack. Signpost to your space and local or online NASS branches. Advertise your helpline. So when we combine awareness, smart primary and secondary care pathways, robust imaging and patient-centered support, delays fall. The playbook gives you tested tools, checklists and a national feedback loop so you don't have to start from scratch and you can prove the impact you're making. Our goal remains clear. We have to reduce the time to diagnosis of Axial SpA to 1 year. With your leadership and input and with this playbook in your hands, it is absolutely achievable. Good luck.